Recovery Reform is a podcast that provides educational content while addressing the stigma against drugs and the people who use them. Expertise meets lived experience as the hosts and their respective guests unpack the multifaceted cause that is recovery reform.
Welcome back to the Recovery Reform podcast. I'm here as always with my co-host, Macaulay Sexton, and our wonderful guest, Dee-Dee Stout. Dee-Dee is a force to be reckoned with in harm reduction advocacy, and is here today to discuss sort of harm reduction and harm reduction therapy and sort of what harm reduction really means. She's been in this space, doing this work, doing this advocacy for a while in the Bay Area. And so I appreciate you so much for it. And I appreciate you, Dee-Dee, for making the time to come on with us. So I would love to fill us in just a little bit about your background and how you got into this work.
Oh boy. Well, that could take a long time. As we used to say, the Reader's Digest condensed form is I went to drug treatment. I came out of drug treatment. They told me I'd probably make a good counselor. I decided to do that. I did the traditional 12-step model, found that worked for a while until it didn't. And then when it didn't, I moved on to other things. In the meantime, I was in school. And lo and behold, came across this whole other world that said there was more than 12-step. And there were other ways of looking at addiction, or what we now call substance use disorders, or just substance use. One of my graduate teachers kept saying, just keep coming back. I thought, I remember hearing that, but it was in a different context, and now I'm hearing it in graduate school. And there's something about this that I'm really fascinated with because I love to learn. So I kind of jumped in, and I had my sponsor in AA. His sponsor was Bill Wilson. So I had this pipeline to a bunch of stories and kind of how Bill actually saw things later in his life, and discovered that the way that people were kind of taking over this thing we call 12-step wasn't really accurate. And so when I said, I think I need to leave, he was the only guy that got to call me baby. Baby, go ahead. Do what you need to do and don't worry. And he hung with me. He was also a medical doctor and the chair of the OBGYN department at UCSF. And so one of the first addiction doctors, if you will, and we didn't even have that word then. And he was on my graduate committee as a result. So he stayed in my life. And that was the other thing. Until he died, he was in my life. And that I found out was very unusual. So I really appreciate people who have a completely different experience in AA and with 12-step in general. And I had a little bit of that from some of the people, but not from my direct folks, if you will. And, one thing led to another. And I finally went and got trained in motivational interviewing around 2000. I had kind of burned out telling people what to do and having them not do what I tell them to, the traditional way. And
the paternalistic way that removes their autonomy.
Exactly. And I went, and I remember talking to Bill Miller afterwards because he was one of my trainers and was in tears and said, thank you for giving me my career back. I can go back and I can do this now because now I know the pressure never should have been on me. As if I had the power to make people change anyway. How absurd and egotistical is that? Like Jesus. And I have another tool. I have a better tool that is respectful and it's compassionate and it's humble and says, I might know some things about how I changed my life and how I became abstinent, but I don't know shit about your life. And I need to know that if I'm going to be of any help to you. And, I don't have to help you. It's okay. You can do whatever you want to do. And I won't care. It won't change my life one iota. So what would you like to do? And have that kind of really open conversation, more like curling up on a chair, grabbing a cup of coffee or tea and saying, let's just talk and examine where you are. with what you're doing. Find out if you want to make any changes. Yeah.
So you went from being essentially like the intellectual granddaughter of the OG of AA to
who I never met, I should add.
Yeah.
Yeah.
But then working with some of the sort of leading thinkers, creators of motivational interviewing.
Yeah.
And that then took you to this different lens of removing the paternalism, embracing the autonomy of the people who are using drugs.
Yeah.
And that then led to harm reduction.
Yeah, there was one more step. I also went to Chicago and studied with Scott Miller and Barry Duncan. They've written tons of books, but the book then that they wrote was called The Heroic Client. Sitting on my shelf behind me, got all kinds of little tabs sticking out and all over. It blew my mind. So between motivational interviewing and this, and what they were talking about was outcome oriented. And the outcome of treatment was determined by the client. So they had this measure, still have it, and it's evidence-based, that asks 4 questions of people. And essentially says, how has your life been since the last time we met? Yada, yada. Then on the other side, it asks the client to rate you every session. My therapist was listening to me. We worked on things I wanted to work on. Again, 4 items. That's it. And looking at that feedback and saying what we need is feedback from each individual client to tell us, are we on the right path? And have that conversation with somebody. So yeah.
Feedback informed treatment, essentially.
Yep, exactly.
And how in that space did you leverage these tools that you had learned from a variety of kind of ideas, essentially, that you kind of condensed into what you do? And not just what you do in terms of like your professional life as a therapist in a harm reduction frame, but also in your advocacy for harm reduction and what truly harm reduction is and what it means, or what it means to you.
So I became friendly with Alan Marlatt, the late Alan Marlatt, who wrote the original books on both harm reduction and relapse prevention. And I actually came to harm reduction through relapse prevention. That was my focus. And mostly because I still am fascinated with, and I don't mean that in kind of the way that it sounds, I guess, but fascinated with how and why people return to whatever the old behavior is, or, what they were trying to change. And because of that, what I discovered was that relapse prevention is actually harm reduction. And Alan and I had these great conversations about this. And that led to my wanting to write this book, the first one, because I found all this harm reduction in 12-step in the original writings and in Bill's talks and whatever, and in the conversations I had with Doc Earl, the UCSF guy. And also, all of these things are kind of congealing and coming together. Now, then remember that Pat Denning wrote her book, Practicing Harm Reduction Psychotherapy, and I know Pat well and trained under her. And then Andrew Tatarsky in New York, wrote his book on harm reduction psychotherapy about 3 years later, and Andy's an old friend. So, all of these sort of people and forces are congealing for me and saying, wait a minute, there is another way to do this that is the right way. Pat Denning's partner, Jeannie Little, and I were on a grant for the San Francisco Department of Public Health together. And she recalls this one day that I went to her and said, teach me about harm reduction. I get it from the books and all, but I'm one of those, I need to see things and talk about things before it's really going to set in my head. I blame it on my Asperger personality. And we were having lunch and she says, oh, thank God, another one bites the dust. And then she apologized quickly and said, I'm sorry, I didn't mean to offend you. And I said, no, you're not offending me at all. I'm kind of curious what you mean by that. And I think I get it. But, she was speaking to, here's another medical model, 12-step only, abstinence only person that says, wait a minute, what the fuck are we doing? This is not the way to treat people. This is not helping anybody with a substance use. I won't say anybody. Occasionally, and I was one of them. I'll take a side tour on that in a second. And really what they taught me was, again, this idea of listening to people. So whether it's feedback informed, whether it's motivational interviewing, whether it's relapse prevention, right? All of these things are coming together and saying what they have in common is deep listening and compassion.
Yeah. And are not paternalistic.
Right.
Specifically.
Right.
And that's,
Absolutely.
Macaulay and I talk about this probably too much, but anybody who's listened, anybody who's listened to this, to our prior episodes will have heard this theme running through them, is that we address it from the frame of, we're not here to be paternalistic, because that's not what's helping people. What's helping people is meeting them where they are.
That's right.
And understanding them. And it includes treatment. And that's one of the things I wanted to ask you, right? It includes treatment, it includes therapy, it includes all of these things to help get people well.
Yeah.
Right. And it's this umbrella term.
Yep.
And it's kind of been boiled down to, the phrase like Narcan and needles is harm reduction. Yeah. And that's not true nor sufficient. That is a part of what harm reduction means, to truly practice and go out and be a harm reduction provider, is to be able and willing to dispense, clean needles and syringes and give out Narcan and work on risk reduction tools and strategies for people who use drugs, but also includes these models of treatment and models of therapy that you talk about. You talk about in your books as well, which is really where I sort of found you, was understanding this harm reduction lens as a larger sort of scope. Yeah. And I was wondering if you could talk about how you saw, because you came to harm reduction from this really broad perspective, sort of more like at its founding, as all of these tools were starting to coalesce to form what is really harm reduction treatment, harm reduction based treatment and therapy. You were sort of right at the forefront of that, and then you've seen it.
I call it 1.5.
Yeah,
generation 1.5.
And then you've seen that get boiled down to minimizing what harm reduction is, and so what has that looked like, and how has that sort of changed your perspective in terms of harm reduction?
And that's a great question, because it hasn't been until the last few years that it really began to frustrate me.
Yeah.
And then it started frustrating me enough, and this is generally how I work, that then I start thinking about it. And then I start kind of pushing back a little bit and just adding, when people would talk about syringe exchange or whatever it is, and go, yeah, absolutely. And let's not forget, because what I discovered, I actually heard a colleague of mine who I don't know, but we're in an organization together, was on a podcast and talking about harm reduction and motivational interviewing. And they explicitly said there is no harm reduction treatment. And I went back and I played it again just to make sure I heard it right. And I did. I sent that to Pat Denning and said, are you hearing what I'm hearing here? And she said, oh my God, yes. We both wrote kind note, got no response. That's okay. But said, and this is someone who is saying they're a harm reductionist and they're a PhD candidate studying it. Well, Alan Marlatt was talking about harm reduction psychotherapy in 1998 in his book. Pat's came out in 2000 and has a second edition. Andy's came out in 2003. It's like, wait a minute. How can you be in school studying harm reduction and not know these seminal books, let alone a bunch of other ones that's practically my whole top shelf that are on harm reduction and various aspects of it. So something is wrong. And then I start realizing that I think part of the pushback that we're getting currently from all kinds of places is because people aren't understanding that harm reduction is more than Narcan and needles. That's where we start oftentimes, is the Narcan and needles. You got to keep people alive, of course. I can't have a conversation with someone if they're not alive.
Right.
And then, not but then there are other aspects. So in this book, I started thinking about it and went, I think there's like 3 distinct categories. There's the policy wonks, and we need those folks that are pushing, like Chad Sabora, right? He's both on your podcast and in my book. We need those people desperately that are doing that kind of work. And these are not necessarily silos, right? And then we've got the boots on the ground, the Narcan and needles folks. Thank you. Absolutely. Because I can't do that work anymore. My body will not take it. And the third category that we really don't talk about is treatment, or counselors and therapists and coaches and whatever they are. Could be MDs, right? I mean, anybody who is working in treatment actively and from a harm reduction perspective. And it's like, we've been doing this for 25 years now. What do you mean we don't exist?
And I could not agree more. And that's why I emphasize every time I talk about my clinic here in Sacramento, we are a harm reduction based addiction medicine treatment clinic. That I lead with that, right?
Yeah.
Because treatment can be part of harm reduction.
Yes.
And you can treat people with that harm reduction lens. And really what that means to me is that we are approaching them from the perspective exactly as you talked about. Motivational interviewing and getting feedback informed treatment, and ensuring that we are meeting people's needs and meeting them where they are and not judging them.
Right.
And then one of the things that I appreciate the most is when I get feedback from patients that they appreciate, that they know that they're going to be able to come to us and not get stigmatized and not get judged. And we have patients. I had a patient just the other day who left treatment with us for months and was like, I was nervous about coming back, but I know every time I come here, I don't feel judged. And I appreciate that. And to me, that means everything. Right?
You and me both.
That's that's the win for me, is having a patient feel comfortable coming back and to tell me that means a lot. And so that's why I lead with that. And it's in part to try to break down this idea that harm reduction is only the people who are out handing out Narcan and needles, because it's not that. It's much more. It's an entire mindset, really. It's how you're approaching the patient. And that can be across the entire spectrum, the entire continuum of use and care. And so I appreciate you breaking that down. I think it's interesting to think about in those three frames. I won't call them silos. Because they all operate,
they cross over a lot. In fact, many of us are doing more things than one, right?
And so in that intersection is where we see the impact of policy, right? And we need people doing that work and advocating on a political level for a harm reduction framework.
That's right.
We need the Chad Saboras, and what we call that the political determinants of health, is the way the policies impact healthcare.
That's right.
So we see the policy lens being important. We see obviously the boots on the ground harm reduction work on a street level being important. And then that entire piece of treatment is probably the biggest slice of that pie, right? Is the people who are doing the work and helping to support people who are either actively using or are seeking recovery, whatever that looks like to them, and respecting that. And that's a whole lot of people doing a whole lot of amazing work that are being counted out entirely from this conversation. And it frustrates me to no end that is carved out when people say, well, we don't need harm reduction because you're just enabling people and you're just, giving out clean needles. Or worse, they're like objecting to, well, we can't give people safer smoking supplies because that's even worse. It's like, how is that worse than needle exchange? But again, like, all of that work is important, and I don't want to discount that at all, how important that work is. And it's so important to factor in the people like you and the people like the clinics that are doing the work from a harm reduction frame, the people who are in the recovery spaces, in the residential treatment programs, who operate from a harm reduction lens, trying to meet people where they're at in terms of what their goals are. That is harm reduction. And if we write that all off, then we lose the audience, because not everybody is ready to accept the idea of Narcan and needles. Sure.
Hands off. Completely.
But what about the treatment? What about the fact that we can respect people's autonomy and not be paternalistic in our approach to them and tell them how they need to change? And they can come to us and tell us how they want to change. And we can help support those goals.
That's right.
If you take that away, then you're losing a critical piece of what harm reduction really means.
That's right.
And so I explain this to people. I have a lot of people come up and ask me, because I give talks and, I'm an addiction medicine physician, and they come up and they're like, how, as a physician, do you believe in harm reduction? I'm like, what do you, I'll ask them, what do you think harm reduction is? What does that mean to you? Because they'll ask, like, well, what about abstinence? I'm like, what about abstinence? People can be abstinent and be working in a harm reduction framework.
I'm one of them.
They can be seeking, they can be seeking treatment to obtain abstinence through harm reduction. And that is okay. But I think people find it, they believe that is discordant, that one means specifically it's not the other.
Recovery or.
It's like, you can only be in harm reduction if you're supporting people who still use drugs. It's like, I'm supporting people whether or not they use drugs. And if you change the language, it's that simple. Abstinence can be a part of that, whether or not. But just because they still are doesn't mean I stop helping them.
And Taylor, to me, it's just like how you support people, you treat them if they're in a car accident.
I'm going to cut them off.
Exactly. And say, okay, were you wearing your seatbelt? Oh, you weren't? Okay, we're not going to treat you. Sorry. I mean, you might have a conversation with somebody, if allowed, about it might be helpful if you wore your seatbelt, buddy. We'd really like to encourage that, but you're not going to deny them treatment because they weren't wearing their seatbelt.
I love that example, because one, as like an emergency medicine physician, like that is, that's rings so true. But also, seatbelts are a perfect example of a harm reduction tool, right? You're literally, the goal is to reduce risk of what happens if the worst happens, if you get in a bad accident. Instead of flying through the windshield, you won't. Literally, even just a harm reduction
deadly
tool.
Vehicles.
And just like we know there is deadly contaminated drug supply that's highly potent, and not everybody's gonna wear their seatbelt. It's just not gonna happen every time. And not everybody's gonna not use drugs. And the idea that is, we live in some sort of like weird, I don't even want to call it a utopia, because that would really not be ideal. I mean, drugs are important, an important part of society. If we didn't have drugs, like medicine wouldn't exist, for example. So I won't even say it through that lens, but this idea that people won't use substances recreationally or use from a toxic illicit drug supply is just false. I mean, the only way we could achieve a non-toxic drug supply that's not highly potent and dangerous and contaminated would be a safe supply of regulated substances. But I don't think a lot of people are ready to have that conversation.
That's not going to happen in my lifetime, I'm pretty sure. Hopefully in yours, but definitely not in mine. Might take until my granddaughter.
What are you talking about, Dee-Dee?
Yeah. My dad was an advocate of that back in the 60s.
Your dad was far ahead of his time.
And he was.
Definitely.
And he sold hospital supplies, so he was interacting with doctors in hospitals all the time. And in those days, obviously it was the 60s, so there was a lot of drug use and a lot of problematic drug use and a lot of overdosing. And overdose in those days, you didn't come back from, right? So, he used to say the reason that he was an advocate for legalization and management, if you will, some sort of safe supply, which we didn't call it then, was so that when people showed up at the emergency room to you, Taylor, you could say, what did you take? And they could answer, and there'd be no fear of answering, and they would be accurate in what they were answering. And you'd go, okay, this is how we're going to treat it. Instead of having to wait for the blood test to come back to see what the adulterants are, to find out then that person might be dead by that point. And everybody's left with that now. All right.
Yeah, 100%. I think that even just culturally, not even considering the systemic implications, but culturally, there's this stigma that really feels preventative. Like when you're in that space, it feels like you cannot say certain things.
Yeah.
And then you're kind of met with this energy that's like pointing the finger, like you need to take responsibility for this. And it's,
if I hear that phrase one more time.
and I think that sometimes that finger needs to be turned around.
Absolutely.
And that people need to think, hey, how are we addressing people? How are we communicating? And me and Taylor have talked about this a lot.
Yeah.
What's your energy like? Not to be like woo, but like, what is your vibe like? Is your vibe
right?
Is your vibe setting the tone for someone to be able to open up and share what's going on with them? And I see a lot of trends and everything that we've discussed today, as far as, again, kind of me and Taylor's broken record of paternalism and authoritarianism, but ultimately what I'm honing in on, based on what we've discussed, is we have a cultural issue.
Yeah.
So we've addressed, politically, systemically, in medical spaces, in treatment, and my soapbox is cultural, because
it's
I
mine
feel
too. I call it.
Yeah, it's so prevalent, it's so prominent, and that is how I believe we can create more person to person kind of change and actually foster more effective communication with people.
Yeah.
And that again ties back to this concept of harm reduction being just, naloxone and needles. It's like, I think that to let it be known that this is like a philosophy and a way of life that everyone can embody, I think is extremely important. And that, again, like Dee-Dee, you referenced it, and we've touched on it, but I think that these things are not mutually exclusive when we're talking about, recovery, treatment, harm reduction. And yes, as far as like the origins of 12-step, I'm like a former fundamentalist, so I understand the initial, kind of implementation of that. And even, people reference this all the time, but there was often alcohol in the room,
right?
Well,
and it was expected. It was in the big book. You were supposed to do that for newcomers who might have a difficult time withdrawing.
Yeah.
I mean, that's why there was bowls of candy in all the meetings, was to help people to get through a meeting while they're starting to withdraw a little bit, and give them that sugar, because alcohol is mostly sugar. So they knew.
It's something that I believe, ultimately, I believe Bill W. was a victim to the dogma that was, solidified within that space. And that, in all honesty, it's very interesting how, we can acknowledge like some of his behaviors. A lot of them probably were, very problematic. But with that being said,
Nobody's perfect.
When it really comes down to it, I think there was a willingness to remain teachable and to continue to look at things, and that was just shot down. And I think that we've seen systemically with the disrespect of the traditions and the implementation of 12-step within treatment and recovery housing, which should not exist. If we really get down to it, it's like the dogma and this like cultural misunderstanding has ruined it in so many ways. And at the same time, do I agree with the fundamental literature? No, I don't actually at this point. But the old way of doing it actually is like way more legitimate and is not infused with a lot of these sentiments and cliches that are not grounded in any sort of evidence, And I think that when I find someone who exists in that space that I like, usually what it is that they actually have retained aspects of themselves and their humanity, and it's not been deleted or invalidated with cliches and kind of bullshit rhetoric.
They're not a walking bumper sticker.
Exactly. And so it's with that being said, I can at this point, based on also what you acknowledged, Dee-Dee, through experience, which is obviously anecdotal and biased, but I think anyone who spends enough time within these spaces, whether it be systemically, professionally, or just like peer to peer, if you have a little bit of awareness, you're going to start to see, hey, what the fuck is going on? This is not working. And that's where you arrive at all of the modalities clinically that you're speaking to. For someone like me, who is not a clinician, I just kind of was like, I guess I need to just ask people what they want. And I guess I need to just stop trying to tell them what to do because it's not working at all. And I really I'll end with this because I really wanted to echo this and just I appreciate you mentioning this, is that it takes so much pressure off of you.
Oh my God.
To be like, hey, I can literally just be like, hey, I support you unconditionally. And then that ties into what Taylor said. Then people will come to you when they're struggling, when they would otherwise go to no one else. And so you always have that lifeline for that individual, and it's unconditional. So that is ultimately, if you would have asked me, hey, what kind of support do you want? I'm pretty sure I would have been like, that's the kind of support I want, not the like finger pointing, bullshit tough love thing, because love isn't tough. It can be challenging.
Thank you.
But
it shouldn't be, right? That ain't love. That's great. And I should add to that, I mean, one of the things, I didn't mention this in the intro, that happened that was significant. I burned out. I don't have, you can't see it, but on the top of my shelf, I have a writing crop, little leather whip that I use. That was a gift from my last patient at the hospital. Okay? Because that was his experience of me as his counselor. Now, the worst part has yet to come, right? Wait, there's more, as we used to say. That was a compliment he was giving me. I went from about a 2,000 square foot home to my 740-ish here. That writing crop makes every cut, and always will, because I know that's still in me. I'm still capable of that. And the work I do today is all I can do to make up for the 7.5 years that I did that kind of work. Because I can't change that.
No, it's, right? I think something that so many advocates, professionals, clinicians experience in general, because you're exposed to, first of all, it has to do with caring. That's my belief, is that when you care about people and a vulnerable group of people specifically, and people who are marginalized and being affected by a specific issue, and you're passionate about that, then there are going to be emotions tied to that when you are not seeing the desired result that you are projecting. And so, and that's the thing, is it becomes this fleeting thing that you never really, it's the carrot that you never get. And, I had to acknowledge that in myself, that because of the kind of intense experience that I had and the intense approach that I received in treatment, that I am capable of being very, very intense and almost just like angry in my attempt to help people.
Yeah.
And, you know, and it also then
Yeah.
I think a lot of people become not only burnout, but jaded when you're result driven and you again are not seeing the desired
That's
result.
right.
But I think that that's an issue with the standard that we are setting and projecting, instead of acknowledging that, hey, we actually, success is all personal. It's all based on what someone defines as success.
Mhm.
But you know, we don't need to be success driven, at least when it comes to just person to person communication and advocacy. Obviously there's different, you know, clinical implications to that when we're talking about success and stuff, but like,
Mhm.
yeah, I think that I just want to acknowledge myself that 100% I fell into that, and with the people who are closest to me, actually, you know,
Yeah.
with like family even, and
Yeah.
and with like people who I was very close to, I found I
Yeah.
felt justified and entitled to be very intense in my approach, and that's exhausting, and it's
Yep.
just such a relief to not be in that anymore, you know?
Yeah.
I think
Yeah.
that one of the things that I see within medicine, and medicine being still struggling with its own paternalism, very much
Mhm.
so, is
Absolutely.
that a lot of people that I talk to within medicine struggle with this idea, not just because, like, the idea of not being paternalistic. And they may say, I'm not, to say, well, how do you feel when a patient isn't doing what you say? And you're like, oh God, that's so annoying. It's so frustrating to me, or whatever. Like, what would happen if you didn't?
Mhm.
What if you were just like, hey, what do you think about this? And like, why aren't you taking your meds or whatever? I
Mhm.
mean, a huge factor is that it's really challenging for so many reasons. There are often so many steps with being able to be adherent to a medication regimen,
Oh
right?
God, yes.
I can barely take anything once a day. And whenever
Yeah.
I prescribe a medication for people that's like multiple times a day, I'm like, I am sorry. Like, and I work with people, like, what do you think is reasonable? They make a version of this, of a version of medication, an antibiotic that'll work for this, that's twice a
Yeah.
day. That
Yeah.
work, right? And it's funny because when I ask people, like, what if you took an approach that wasn't like, hey, do this, and then
Mhm.
they come back and they didn't do it? If you're just like, how can we best address this?
Mhm.
And they're like, well, I
And
don't
I
want,
love that. I'm
yeah,
going to interrupt you just because
yeah,
I go through this. I have an entire medical team now
right,
because I've developed well, the symptoms came forward strongly, called Sjogren's disease,
oh yeah,
and
yeah,
it has knocked me on my backside for 3 years. I am now the best I've been in 3 years,
well,
and
that's
it has
good.
been brutal. And so I've got a rheumatologist, I've got 2 dentists, I've actually 3. I've got my primary, I've got somebody else, I can't even think of that there. Oh, an ophthalmologist, you know, and somebody else in there. So I have this whole team, and they all have things they want me to do. And I finally looked at one of them one day and said, I'm not going to do it. Okay. I can tell you right now, I don't have any more energy. I have to work. Nobody else. My cat is clever, but not good at paying the mortgage. You know, not going to work here. So what I need from you guys is to help me to stitch myself together enough that I can work. And then I'll try to do a little bit extra to take care of these other symptoms that I'm having. You know, and I have to be able to walk. That's
Right.
all I give a shit about. I got to walk at the water for my mental health, and don't have to do it every day anymore, but I got to do it at least partly. That's what I need from you. And it was like, you know, I lost one of the doctors
Yeah.
because of my refusal.
And
But that's
imagine
okay.
how much better they would feel if they took that pressure off
Yeah.
themselves. Because
Yeah.
it's not on them. It's not,
No.
And a lot of times people feel like it is my responsibility to do this because
Well, I
that's what
think
I
that's
signed
what
up
we're
to
talking
do.
about.
Right.
You know, in healthcare, when we're working in healthcare, and I was trained that it was my job to get people, they had to, by the time they left treatment, 28-day hospital based, right? They had to call themselves an addict or an alcoholic. They had to have worked the first step, and we were supposed to get through their denial. Those are kind of the three main things. Well, good luck with that.
Yeah.
Right?
Yeah.
God, there's so much wrapped up in that statement alone. And I think the visual of that, like how powerful the writing crop is, especially for you. And also the guilt. Yeah. The guilt associated with that.
Yeah. And that's 35 plus years ago.
And I can tell you personally for myself, having been a full-time emergency medicine physician who then sort of picked up addiction medicine along the way and has transitioned a lot of my time to doing that, it has changed the way I approach emergency medicine. And that frame shift is truly the thing that helped me the most in enjoying being a physician and staying in healthcare, is that I all of a sudden was like, oh, there's a way I can do this where it's not, I don't feel bad or guilty, or it's not my fault that I can't control other people's behavior. Right. The idea that we can, Macaulay, you mentioned this, is like the idea that you can control somebody else's behavior is, it's insane to think that. And also somehow that's what we expect.
Yeah.
It's what we expect to do in addiction treatment, in that framework, Dee-Dee, that you were talking about.
Yep.
It's what we expect out of healthcare.
Yep.
And so it's like this self-perpetuating cycle too for healthcare and for health professionals. Part of why they adopt that lens. It's like, oh, but you are in charge of fixing me. It's like, that is not helpful. That's not a helpful lens for society to view healthcare and treatment.
Yes.
And that's not a healthy lens for us as health professionals to view patients. And so
thank
wouldn't
you for
be
saying
nice.
that.
Yeah.
Right?
Yeah.
Because one of the things I've come to the conclusion of, and I think you have too, and maybe you too, Macaulay, is that we, society, and particularly healthcare workers, have really well trained our patients to be subservient, to be helpless, to come in and say, oh my God, doctor, I hear this. Dee-Dee, you can help me to, stop drinking or whatever it is. No, why do you think I can do that? But we fall into that hero piece, right? And there comes my ego, and I've got an ego like everybody else, and I can get a puffed head and go, yeah, I worked with thousands of people. You're right. I can do this. Stop it. No, you can't. You can't even make yourself, whatever on time.
Right.
That's right.
Like me trying to get here for this.
Right?
I couldn't get here on time, and I feel pretty in control of my life.
Yeah.
But no, I get that.
Yeah.
And I think one of the things, sort of to go back to what we were talking about in terms of the trust that builds with patients, is I had a patient who recently asked me, he has he's been with me for a few years now and has returned to use multiple times throughout that, but has had periods where he's done really well in his recovery, whether abstinent entirely or not. And he had a return to use, and he actually got hospitalized because of it. And he came back into clinic, and he was like, hey, I just want you to know I really appreciate you being here, and I truly believe I wouldn't if you weren't my doctor, which meant a lot to me.
Yeah.
But then he just paused and looked at me and said, why do you let me come back? I was like,
wow.
I was like, you're not failing me, right? It's not up to me to decide how you live your life. And I felt almost a little taken aback by that. He's like, well, how many, he said, I failed so many times. How many chances do I get? I said, you get infinity chances. It's like, I don't know. Are you still like breathing? Are you still like upright? then you can still come into the clinic. Like, you get infinity chances.
Yeah.
I don't like, I didn't really know how to answer that question, but it struck me so much because it is different. It is different than the idea of that paternalistic, like, oh, you are failing the instructions I've given you,
Right.
or we're going to discharge you as a patient because you're not non-compliant.
And
it's like,
yeah,
it was so interesting to me, and that conversation will always stick with me because it was really heartwarming to hear, but also devastating because it's like, you're so trained to be like, I am a failure as a patient. And from the healthcare provider side to be like, that's it. They're a failure. I can't help them. Yeah. And it's like, I didn't feel like I haven't helped this person. He feels like I've helped him. Right.
Yeah.
So obviously I feel good about the fact that I've helped him, even though he got hospitalized as a result of returning to using. Does that mean he's a failure? No. Does it mean I failed in helping him? No. It just means we have to continue working and moving forward to help him get to a place where he feels like he is in control of his recovery again. But it was just this moment that really struck me about exactly that issue, that sort of like paternalism and the trust that you build with patients when you sort of break that down.
Yeah.
And exactly like you said, Dee-Dee, that we have trained patients to view us as health professionals in that way. And that's destructive for us.
Yeah.
It's destructive for patients.
Yeah.
It's destructive for the idea of recovery because it again, like, I mean, why we titled the podcast what we did, we want to reform that idea of like, recovery isn't abstinence. Recovery isn't what I say it is. Recovery is what you say it is. Recovery is what the person who is using wants to recover in terms of the active word of what it is to recover something. And so I think it's just so important for that lens to be applied, exactly like you said, Dee-Dee. And I appreciate your sort of like personal anecdote there as somebody with Sjogren's disease. How hard, I mean, for context, it's a rheumatologic disease, an autoimmune disease. That's difficult to manage.
Well, just put it this way. I woke up with my tongue stuck to the roof of my mouth one day and went, what has happened to my body?
And like everything felt like it was dried out. And I mean, that's what's going to happen. And so you want, especially if you're in a position of dealing with a person with an autoimmune disease like that, to be like, okay, how can we best support you going forward? Because an all or none response to that is not going to be helpful.
Yeah.
And so that's such a great example to sort of crystallize the importance of this, not just in the substance use and recovery space or harm reduction lens in terms of as applied to substances, but as applied to all of healthcare, really.
That's right. Yeah, having this has given me another layer of perspective on how important harm reduction is in its principles and its foundational pieces in all areas of our life. There isn't any area that, I guess bottom line for me, we got to get out of these binaries. Yeah. We Americans particularly we just love our binaries. It's right or wrong. It's black or white. That's it. There's no conversation. There's no critical thinking, as my son says, happening anymore. He's in his 40s, and I go, yeah, you're right. And it drives him crazy, which is good. It should. And it's just sad because it's like, it's like working with two crayons in the box, right? Come on, guys. There's all kinds of different colors in here, but we see it in all kinds of different places. So whether it's defining recovery by abstinence and people saying, well, how does that affect my recovery? If you're using a substance, Macaulay, and I'm abstinent, how dare you call yourself in recovery? Why is that affecting your life? I mean, it's the same thing we go through with queer rights. Like, how is queer marriage affecting your marriage? I don't understand that. What has one got to do with the other? In fact, if you like marriage, you should be excited. You got a group of people who want to be married for some crazy reason. I don't know why, but it's like, just get out of that binary
Yeah.
and stand back for a minute and take a breath and look at what's going on.
Sort of
And
zero-sum thinking
yeah,
in terms of
that's a good way
how
to put
that's
it.
viewed.
How sad.
Yeah.
How to sort of bring it back, Dee-Dee, to talking about the therapy aspect
Yeah.
of this. How do you take that approach and apply that lens in a therapy space? I mean,
Yeah.
neither Macaulay or I are therapists,
I'm not either.
but how? But
I'm not.
but
I'm not a
from
licensed therapist.
that's from the like counseling
Yeah.
space. How do you view that in terms of the treatment aspect from a harm reduction lens?
That's a great question. So one of the things that I like to do with folks, I mean, first of all, and I do tell everybody I'm not a licensed therapist in the state of California. I have a master's, I've got more training, and I'm a professor who trains the next generation of therapists. But that's the irony in the state of California. And that's okay, because for me, it means I can work all over the world, and I do. I don't have any restrictions on that. And so I do almost all of my sessions these days on Zoom. Although I do have at least one client that likes to pop in every now and then, and that's fine with me. And it really is about helping people to examine their relationship to a substance or other risky behavior. And part of the way that I like to do that is with having some really deep conversations about their goals and values in life. And even with the goals and values, so we kind of start there and look at what their goals and values are, but we need to have a conversation about that too. Because sometimes what happens, we hold on to values and goals that are actually somebody else's. They're not really ours. And that's part of the reason we get stuck in behaviors that we can't get out of, because they're not really ours, but we think we ought to be doing it. And, here we go. Or we're trying to cover that somehow and cope with the shame that we have from the family or, whatever culturally. And so that to me is really interesting too, to help people to unpack that in a space and an environment that says, I don't give a shit. And I really don't. I might care as a human being, but in this context, I'm here just to help you examine your own life and decide what you want to do around substances or other risky behaviors. And it's okay. And you can change your mind at any point. And people do that. I do watch clients struggle with this. And I am working with people all the way from, I started drinking a little bit more during the pandemic, and I'm a little worried about that, and I'd like to cut back again. What I would call kind of a moderate drinker that now is heading into that risky area, or smoking a little bit too much pot, or, I really don't have anybody using opiates and haven't had for years, which I find really fascinating. A former client of mine died last week, 2 weeks ago now, and it was alcohol. That's what I see, is a lot more problems with alcohol. And then you can add in some other things here or there. Cocaine's made a real good surge. That's my personal drug. Not nearly as good as it was in my day, though. So, there's that. Long time ago. And methamphetamine has never left California. I mean, we're the king of methamphetamine because we're Silicon Valley. You can't have people nodding off in the corner if they're going to be right in the next app. It doesn't work. So
yeah, and in terms of stimulants, it's never really been cocaine as much as methamphetamine out
so
here.
So to me, that's also
somewhat
out of whack,
but,
right?
Yeah.
But again, it's back to this country. We can only look at one drug at a time. That's it. And then we panic because now you see the thing. Oh, methamphetamine's making a comeback. Comeback? What are you talking about?
Never
You never went anywhere.
Never left here. I did. One of the things you said was interesting to me, was in terms of identifying goals and values and making sure that it's their own.
Yeah.
And owning that. I think that's huge. I think that's really, could you talk a little bit more about that? Because I think that, right, in terms of when we're talking about autonomy, you can't be respecting somebody's autonomy unless they're truly authentically in themselves and their own goals and values.
Yeah.
So that is one of the things that I do think about in terms of asking patients what they want.
Yeah.
Is making sure that I'm respecting their autonomy. But you bring up a good point. I am not asking that question regularly, and I think I probably should.
Yeah.
But talk a little bit more about how you go about having that conversation.
Sure. So let me back up and say there are 5 things that I think of today, and it's changed over the years. So today it's 5 ingredients in harm reduction psychotherapy. And the first thing that we utilize is motivational interviewing, which we've talked about. I want people to know about the stages of change. So I'm a professor, and I don't force this on people. This is always a conversation. If you're interested in how you make change, we can have this. Drug setting, Zinberg's work. I talk about that. I also utilize self-determination theory. So that's number 4. And recently I've added attachment theory as I'm getting trained in emotional focus therapy. And those to me, like I said, right now, those are my 5 bedrocks to things that I do. So for me, talking about goals and values, which comes out of motivational interviewing, right? But it also, I think it works well and intersects with both self-determination theory, but also attachment theory. All right. What am I getting attached to? And who and what am I getting attached to? And how is that affecting my life? I also like to talk to folks about how goals and values often change. And it doesn't mean that I've changed everything about who I am. It just means we have different decades of life and things are going to be important at different decades. And that's normal. That's healthy, to kind of reevaluate every few years and take a look and say, is this still important to me? Maybe it's not. Maybe you've already achieved it, or maybe you realize that isn't really what you wanted to do. You'd rather be painting over here. Okay, cool. Let's focus over in that. So that to me is interesting to do. And one of the ways that I do it is I often in the first few sessions have people use the personal value cards coming again out of motivational interviewing. I do it because they're free. We've already paid for it with our tax dollars, so why not? Yeah. And there's 113, 115, there's a packet of them, right? And I will have people choose 10 and just start there. And I do this with couples and with families as well. And then eventually we wind up talking. So my job is sort of to try to weave in some of those values into most of our conversations. Weave it back to that. So I might ask them, I'm really curious. You talked about you want to be a good mom. And for you, being a good mom is not using an illicit substance. Okay, I get that. So talk to me how using that illicit substance helps you to be a good mom, though, and what that struggle might be. All right. And then come back around and where can you find your own compassion for yourself around this and appreciate raising a kid is hard. I know I did it and I did it on my own, and I was a cocaine user and a drinker. And a lot of times my son would have been better off because I did that than not, because I was alone and scared and family wasn't supporting me and, I didn't know what to do. And I was in violent situations sometimes. So yeah, it was a coping mechanism for me. I'm not proud of that, but I'm also not ashamed of that. That just is. And eventually, I think it would have been better had there been a way for me to approach this in a more stepped format rather than the way that it happened. But that isn't how we do things. No.
I think that that speaks to the fact that, when I have these conversations with people and they're about harm reduction, they're like, well, the drugs are the problem. And I'll say, no. I'm going to reframe that for you and tell you that drugs are the solution.
That's it.
That people found to their problem.
Right.
And so let's find the problem that they're solving with drugs.
Yep. And that is what I do.
Because
so I help families too in that same way, because what I'll say, and I did this yesterday. So here I am using the substance because that for me is a solution for what is going on for me. And here's my family saying, no, it's the problem. We're doing this. We can't help but do this.
Right.
So until we can look at each other's lives through the other lens, we can't. And of course, in emotionally focused therapy, what we say is, hey, you're the parent. It's your job to see it through your kids' eyes, not their job to take care of you. So you're going to have to shift around.
I think that's such a good point.
I want to reference something really quick that just kind of came up for me in what you're sharing, and that there are many people who the main consequence that they're experiencing associated with their substance use is psychologically based on their internal voice and like cultural stigma. And people who are actively consuming substances, in my opinion, can experience the abstinence violation effect before they've ever maintained any level of abstinence in their life. And I find this with many people to where the main thing that's going on is that they're, all right, I'm going to get a little weird for just a second, but within the psychedelic space, okay, when people consume psychedelics, usually they'll set intentions, set and setting, you know, and then they'll put something in their mouth or consume it by other means. And when you're doing this, you're thinking, I'm going to look at this in my life. I want to grow. I want to whatever. Now, let's look on the other side with these stigmatized substances. What are people usually thinking when they consume these things? What the fuck am I doing? I'm a terrible person. What is this? I'm so ashamed of myself. And that 100% affects the experience. And it makes this not sustainable for many people who otherwise it could be completely sustainable, especially if they have a safe supply. And so what I've found, honestly, is that most consequences are systemic or psychological or legal. And in all honesty, I'm not, look, in obviously a principle of harm reduction is acknowledging that, you know, the illicit supply and, you know, there's harm associated with consuming certain things and, you know, aiming to reduce that harm. But I just think that there's often not enough emphasis or acknowledgement on, you know, just the psychological aspect based on the standard of abstinence that's projected onto everyone. And I encourage people to question someone's motivation to be abstinent. And that is like unheard of almost in a lot of settings, because the moment someone says, hey, I would like to, let's say they're using illicit stimulants and they want to start taking prescribed stimulants, the immediate response by like paternalistic abstinence-based people is going to be like, that is dangerous. Why do you want to do that? You're in denial.
Right.
But I find that if we're just like, if someone says they want to be abstinent, immediately we're like, cool, awesome, that's what you should do, you know? And I think that considering how abstinence puts you at risk for fatal overdose and the abstinence violation effect, I think that there needs to be a spirit of caution and harm reduction in the pursuit of abstinence. And
absolutely. Absolutely. Thanks for saying that, because the researcher, Lisa Najavitz, who is at Harvard, I'm not sure where she is these days, she wrote the book Seeking Safety, which has been around for 25 or 30 years now. So in there, she states very clearly that abstinence does not solve trauma. In fact, it can lead to PTSD and trauma. So, and I remember, so when I got trained in that and looking back at the work at the hospital and thinking, of course people are acting out. And of course they get exited for acting out. It's like, what do we expect, right? That we take away, like Linus snatching the security blanket away from what's his name, and I'm sorry, Charlie Brown and Linus taking it, right? And taking it and going, and you should be happy about this, and you need to treat the staff with respect.
Yeah, be grateful. Be grateful.
Right.
So that's such an interesting point, because there's a great paper that I reference about addiction medicine consult services. So I helped build inpatient addiction medicine consults. for hospitalized patients who use substances. And in that paper, one of the things I referenced, and granted, the people who are making the decisions often don't care about this as much as some of the other like financial factors, for example, but I think it's super important, and I'm so glad that somebody studied this, is it builds trust with not just the addiction medicine team, but with all of the other services providing care to those patients, because they get the addiction medicine service gets consulted for, say, somebody who's in opioid withdrawal or uses fentanyl, and they give recommendations saying like, hey, this guy's opioid demand is going to be higher than, you know, anybody else you've treated. Make sure you're giving him enough, et cetera, right?
Yep.
That alone, having people who just understand that and understand the lens by which to treat these patients helps build trust with the entire rest of the healthcare team that is treating them, and that they're more likely to stay in the hospital for their entire sort of during the length of stay. They're more likely to be, you know, more adherent in terms of medications that they're trying to treat them with while they're hospitalized, et cetera. And so I think it's just such a great look at like what is important. And obviously different factors matter to different people, but I think that's just such an important thing to discuss, is like, we are here to help support people. And so how can we best do that is by building trust. And guess what? If you take people who specialize in treating people who use substances to help people who use substances when they're hospitalized, it actually pays off because it helps develop trust in the entire system. Like,
as long as they're coming from a harm reduction perspective, right? It could be damaging if they're not.
Certainly.
And we do still sadly see that, right? That, you know, people will tell me how, and I've heard this from patients, and I know you have, and you probably have heard it in other people saying this, Macaulay, but going to the hospital these days and having surgery or cancer treatment or whatever, and not being given any pain medication, being given Tylenol and said, you know, go home. And if they ask for anything, then in their record goes they're drug seeking.
Yeah.
You know, and again, it's like, why is my comfort bothering you? You know, if you're not going to let me overdose because I'm in the hospital, okay? And if I do, you're right here.
And it goes right back to the point that you're talking about with health professionals being frustrated and then burned out because they believe that they should be responsible for somebody else's behavior.
That's right.
I mean, not that this is even problematic behavior, but just seeking comfort, which whenever people would tell me that, you know, from the emergency department side, they're like, so they'd be like, oh, I think they're drug seeking. And be like, so what you're saying is that they cross the door to get into the emergency department, because literally every person who comes through our doors is drug seeking. Like they're seeking treatment, usually through pharmacologic means, which are drugs. Like they are here, antibiotics, they're drugs. Like they're seeking drugs.
That's right.
I hate to break it to you, but everybody is coming in drug seeking. Like I don't know what to tell you. And so when people are like, no, I mean like opiates. And I'm like, and again, what is your point? Like, they're seeking care. They're in pain. They're seeking opiates for pain. Or maybe it's not because they're in physical pain. Maybe it's because they're in withdrawal, which is a physically painful.
That's a pain.
But
that's right.
Or maybe it's because they just use them and they haven't been able to get any.
Yeah.
And what, we're gonna like force them to go back out and find some or use from an illicit supply? Like, it's not up to me again to decide somebody else's behavior. It's up to me to help people when they are seeking treatment. And literally every single person that crosses the door in the emergency department is generally seeking drugs.
Yeah.
Because that's how we are able to provide care.
Well, what do we do in our healthcare system?
Right.
What's the first line of defense? Give them a drug.
Right.
It's, which I'm not advocating at all, but just saying it seems a little ridiculous to now get upset because somebody wants an opiate versus
exactly
whatever else.
That's
Exactly.
exactly right.
Policing
That's
feeling
right.
good is what
Yeah.
I often say is like, it's
Well,
always tends to be associated with anything that can bring about a sense of euphoria, which doesn't, I do
and
not
that's not
care.
allowed.
Yeah, it's like if
I know.
you feel good at
Yeah.
all,
I know.
nah, like that's not
Pat
okay.
Denning has talked about that a lot, and she would say, point blank, euphoria is not allowed in this country. That's all there is to it, and certainly not if it's coming from a substance. One of the other things that you mentioned, and it reminded me of the late Houston Smith, who is a philosopher and theologian professor at UC Berkeley. And one of the things that he said was when humans started to get into trouble with substances, seems to be when they stopped taking them to get into themselves and started taking them to get out of themselves. And I always thought that was lovely.
Yeah.
It's a little simplistic, and he knew that too, but it was a perspective that I had not quite thought of. And I think that there's some validity to that.
Yeah. It's
And I
interesting.
like to say, why is it that the richest country in the world needs to take all these illicit drugs? What's going on here that we will not look at? We refuse because we're so stuck in it's got to be the individual. It's the drug. It's that if we get rid of that, everything is fine. And then the person needs to be responsible. They need to make change in their life. And I go, so I do this work. We all do this work with this individual. And then they go right back into the same neighborhood, the same home, the same environment, the same whatever, lack of purpose, lack of desire, lack of opportunity. And we expect them to change. Why?
Yeah.
Back to that idea of us being responsible. We're the ones who are screwing up here.
Yeah.
Yeah.
Can't expect people to change without changing the system.
That's
Well, I
right.
appreciate all the work that you do
Yeah.
working to change the system, Dee-Dee.
Mhm.
I want to give you the opportunity to plug all the things that you can. I mean, I know you have your new book out.
Yes. Theoretically, the second edition that became volume 2 instead.
Yeah.
All 42 new stories from people all across the country. I had intended to have some international people in there, and then was reminded that the subtitle of the book is Radically Loving People Who Use Drugs. And a buddy of mine in Australia wrote me an email and said, Dee-Dee, that's not radical. See, that's why I can't write an international book with that subtitle, because you people realize this, but I live here.
Not here.
Yeah. So, because to me, that's what this work is. We're saying to people, you are worth saving. You are worth breathing air. And I know for most of my life, I didn't feel that I deserved breathing the same airspace as other people. And that was even before I found drugs. Actually, drugs helped me to reduce that feeling. We'll just put it that way. So, and I'm not alone in that. I know that. And that hurts my soul. So,
well, I appreciate you. Everybody go out, look up Dee-Dee Stout.
Coming to Harm Reduction, Kicking and Screaming.
Oh man, great title too. Look up her books, buy them, and thank you so much for coming on, Dee-Dee.
Thank you
really
so much.
appreciate you and all of your work.
Yeah. And same to you guys. We all have a place in this big umbrella that harm reduction lives under, and we need everybody in the pool.
Yeah, you bet. You bet. All right. Yeah. Thank you all for listening or watching. Have a good day.
Views and opinions discussed on this podcast are personal and do not reflect the views or opinions of our employers. Although medical and clinical topics may be discussed in this podcast, the information provided is not medical nor clinical advice. Thank you for watching and or listening.